off as normal. By moderate, they're short of breath on exertion and they start seeking attention, medical attention, usually at this stage. Stage 3, it's definitely having an impact on quality of life, increasing shortness of breath and reduced exercise capacity. And stage 4 is very severe. Chronic respiratory failure and the exacerbations can be life-threatening at this point. Looking at the spirometry, we classify this also. Just briefly, FVC is a forced vital capacity that we get in pulmonary function tests. It's the amount of air that you can take in and blow back out. And we measure that total volume. The FEV1 is how much of that volume can you blast out in the first 1 second. And for normal adults, you can blast out 80% of your total lung volume that you're able to breathe in and blow back out in the first 1 second. But when there's obstructive disease, that FEV1 is going to be reduced. So in moderate, it's 50 to 80%, and on down, very severe, less than 30%. I've done pulmonary function tests on COPDers that have an FEV1 of 13% of predicted. So very advanced. Key factors to reduce the risk factors similar to an asthmatic, and they can react to anything, again, to the irritants in the air. The other thing is the smoking cessation is huge. These are a few things to cover as far as trying to talk to a patient to get them to quit smoking. Montana does have a quit line. I'm not sure about the funding about that. I hear it got cut with the recent legislature, even though the quit line is funded by the Montana tobacco settlement money. But at this point, it's still up and running, and they can help patients buy some of the medications so that they can quit smoking. There's counseling available. It's a great resource. Managing stable COPD, again, is looking at everything to do with their quality of life, tons of education similar to asthmatics, and the proper use of medications also. So COPDers can have an action plan just like asthmatics, and it's very similar, everything on there just like the asthma action plan, except it's also going to include their oxygen setting. Go for the green zone, and on every one of these, they also need to still take their daily meds and oxygen and avoid their triggers and continue their regular diet. Yellow zone is a caution. They're going to have more symptoms of a flare-up, more mucus coughing. They may have more ankle swelling, less energy. At this point, they usually will be started on an oral steroid and maybe an antibiotic. Danger, this is of course when the chronic lung patient needs to be seen immediately. They're short of breath even at rest, not able to do any activity. If a person's talking to you in words instead of sentences because they're so short of breath, leaning forward, what we call tripoding, trying to breathe, labored breathing, all of those are signs that they're in the danger zone. Okay. Bronchodilators are central to the treatment of them. Principal bronchodilator treatments are our short-acting beta agonists and our anticholinergics, and they are most often used together. Long-acting beta agonists are more effective and convenient than short-acting beta agonists. This is something that comes up all the time. We have patients admitted to the hospital for something other than a pulmonary disease. And because we have medication reconciliation forms, the admitting doctor reviews their home medications, hits continue on everything, and does the same thing when they leave. So they come in, and these patients might be on albuterol and Atrovent QID or Q4, and they've been on it for years, and they really probably could be managed on a longer acting beta agonist and anticholinergic than the labor-intensive 4 nebs a day or a neb every 4 hours. I think it's kind of a vicious cycle because if they get short of breath in between treatments, or if they're, say, a QID treatment and they wake up short of breath in the morning, they're more focused and dependent on that medication, whereas they could be on a long-acting beta agonist and a long-acting anticholinergic like tiotropium, and maybe not be so focused that they have to have their treatments all the time.
In long-term care, we're always giving people, what is
It's short acting.
We're
Yeah.
always giving QID, it seems like.
People come in on Duoneb, QID, all the time. And
That's
Duoneb is albuterol and ipratropium, and they're both short-term. So, and that's fine if they, it's not fine. Some patients need that on top of long-acting ones, but if they need a short-acting beta agonist 4 times a day, they probably need to be on a long-acting one instead. It's very labor-intensive. And like I said, I think it's a vicious cycle. The patient gets more concentrated on their disease and more thinking, are you late? I mean, they'll page us ahead of time just because they think we might be late for their treatment. So I have to address the top 10 reasons not to give albuterol, because as respiratory therapists, we're paged all the time to give a treatment for reasons that aren't necessarily valid. So had to stop here. Briefly, here's a few of the reasons that we might get paged to give albuterol. It will not cure a junkie cough of a smoker. And these are actual excuses or reasons that we've heard in the past. Because it's something to do for the cranky COPDer. It does not cure pleural effusions. No kidding, I got paged for a patient who just had a treatment a long time ago, and we were triaging emergencies and traumas, and I said, well, is he doing okay? And the nurse said, oh, he's fine, he's discharged. He just wants one for the road. Like, okay. Number 4, to help wean the post-op patient off oxygen, it couldn't possibly be narcotics and immobility, right? I have a coworker who tracked down a resident who kept ordering albuterol Q4 for patients who are admitted with CHF. And she looked at her point blank and she said, you know, albuterol doesn't part the waters. Yes, that was a reason I was called for albuterol treatment, because that's what the patient does at home. And the number 1 reason not to give albuterol is because it's albuterol, not albuterol. It doesn't fix everything. Okay? Reasons for albuterol. Bronchospasm. It is a bronchodilator. That's why we give it. Hyperactive airways. The other thing is, like I said, if the patient's not wheezy, but they have that chronic dry cough, that might be hyperactive airways. Exercise-induced bronchospasm, you give it before the exercise to pre-treat. The other off-the-wall treatment is if you give big doses of albuterol to treat hyperkalemia, only when it's in really dangerous levels and you're using all the tools to treat hyperkalemia. COPD medications, the bottom line with this is it's more effective. This is kind of confusing, but an inhaled steroid and a LABA is more effective than giving them individually or giving one or the other, but the combination therapy does increase the likelihood of pneumonia. And it has no more impact on mortality, but it does help reduce exacerbations. And adding the LABA and the ICS combination to the anticholinergic, that tiotropium is a long-acting anticholinergic, is beneficial. This is the therapy at each stage of COPD, and this is a busy slide also, but what you look at across there is adding the short-acting bronchodilator in the stages, just like with asthma, and then adding regular treatments with the long-acting bronchodilators. And these would be not just the bronchodilators, but also the anticholinergics that are short and long-acting. Inhaled glucocorticosteroids. On this slide, and this is from the gold standards, they talk about adding it at the severe. Our physicians probably add that a little bit before that severe stage. And at the end, we can also add oxygen, and there are some surgical treatments, but they don't come up very often. The same skills for medication administration apply to COPDers as to asthmatics. If they're not taking the medications correctly, that they're not getting it. And some patients do need a nebulizer. We're very pro inhalers because it's less labor intensive and it's very portable, but some patients do need to take a nebulizer to get their meds. They also need vaccinations. The influenza vaccine is very important. A lot of patients are confused about the pneumonia vaccine. I don't know how many times I've heard them say, I got a pneumonia vaccine, I don't understand why I'm hospitalized with pneumonia. And we have to explain that it's only one bacteria that that vaccination covers, and it's that pneumococcal vaccine. But it's a deadly bug. You don't want to get in pneumococcal pneumonia. But they could still get in, of course, with any other bacteria or a viral pneumonia. Other medications, most of them are not effective for stable COPD other than antibiotics. We don't give the mucolytics, antitussives, and vasodilators regularly. So, what oxygen flow should COPDers be on? And what's the limit to give during an exacerbation? Yep. What? 4? Oh, I thought you were raising your hand. You know, the answer is you go by the saturations. Just like you wouldn't give the same dose of insulin to a different diabetics, you would go by what their blood sugar readings are. But the hypoxic drive theory has been very confusing and misrepresented and taught wrong for a long time to make people think that COPDers cannot be, they should all be on 2 liters of oxygen, or they can't be over 4 liters of oxygen. And the bottom line is whatever their stats are at, okay? Also, you never withhold oxygen from a COPD patient when they're in distress or hypoxic. If the patient's a CO2 retainer, then according to the hypoxic drive theory, which we don't have time to get into, they shouldn't be over-oxygenated. But you just watch the SATs with them, but don't ever withhold oxygen for a patient who's in distress, has low SATs, or hypoxic. Oxygen therapy do's and don'ts. Just a few of the things that I find patients are not told. Okay, so when they go home with home oxygen, it's do wear your oxygen at all times. That means it even goes into the bathroom with you. That means it even goes into the shower with you. In fact, you need it more when you're taking a shower than when you're sitting at rest, okay? And it doesn't interfere with eating. Blowing your nose, yes, but eating, no. You can wear your oxygen while you eat. Do not set off fireworks while you're wearing your oxygen, or smoke, or barbecue, or cook over a gas stove, or use petroleum-based products in your nose or mouth, or use an electric shaver. Don't adjust your oxygen according to your shortness of breath, which they all do anyway, because shortness of breath can be a very poor indicator of what their oxygen level is. And the bottom line thing that I tell patients, if you're short of breath with activity, you either walk or you talk, but you don't do it at the same time, because both of them require extra oxygen. Okay. Most common exacerbations. And these are the treatment options that we have with exacerbations. CPAP and BiPAP. Very often we can get patients by for a few hours or half a day or a day when they first come in and not have to put them on a ventilator. It's very difficult to get a serious COPD off the ventilator once we put them on. We take over that work of breathing for them and they're like, this is cool. And to try and give that work of breathing back to them doesn't work very well. Indications for hospital admissions, mainly if it's severe, sorry that was fast, or if they're not responding to therapy. Or if you're not sure what you're dealing with, or if they're really quite elderly. End-stage COPD care, on that third tier down there under managed oxygen, NIPPV is actually non-invasive positive pressure ventilation, and that's our CPAP or BiPAP. And it depends on where a COPDer is in that, that spectrum of care. If we think we can get them past this flare-up, then we'll try and use CPAP or BiPAP and try not to intubate. A lot of COPDers I do not intubate, especially if they've already been intubated and on the ventilator once. If they're really end stage and they're not going to survive this, the best thing we can do is a morphine drip. Said patients should not be gasping for air with horribly labored breathing when a morphine drip is available. We titrate it for comfort, not for respiratory depression. It usually takes maybe 0.5 milligram to 2 milligrams an hour, and if you need to give a few boluses, you can. But you can take the edge off that air